all three of these, I think, are going to change the landscape of pancreatic cancer in the next decade.
Pancreatic cancer is the third most common cause of cancer-related deaths in the United States. But based on some of the announcements that happened in the last 6 months, a lot of this is going to change. We're going to talk about pancreatic cancer treatments first. One of the reasons pancreatic cancer treatments have been so hard to develop is that the mutation that's known to be present in 95% of pancreatic cancers, known as a KRAS mutation, just doesn't have effective treatment options. For the longest time, we all thought that it's going to be undruggable. But things have changed now.
The median overall survival for the patients taking the pill was 13.2 months compared to the group that was getting that second-line chemotherapy was 6.7 months. So almost double overall survival.
It has to help them live better, and it has to help them live longer.
Efforts in recent years have focused on this principle of vaccination. The idea was to take a patient's own tumor after surgery and to realize the signals called antigens or neoantigens that can be used as remarkable for those patients.
Artificial intelligence can have for detecting pancreas cancer early. These are by definition negative scans most of the times, yet the AI tools are able to differentiate at a pixel level. Pancreatic cancer is the third most common cause of cancer-related deaths in the United States. And for a small, funny-looking organ that lives in the back of our abdomen, that's quite a feat. One of the reasons pancreatic cancer is so deadly is oftentimes it has either spread to local areas around the abdomen, which prevents us from being able to operate on it, or it's spread to other parts of the body or metastasized, which prevents us from offering curative treatment options. So the three major problems around pancreatic cancer treatments, which make it so deadly and so notorious, is that there are no early detection screening methods for pancreatic cancer. For even people who have had the chance for having surgery, by far, most of those patients see a recurrence in their cancers within 2 years. And for people who have stage 4 or metastatic disease, the treatment options that we have today to offer people with pancreatic cancer just aren't as good as there are for other cancers. But based on some of the announcements that happened in the last 6 months, a lot of this is going to change. And we're really excited to bring today's episode to you. We're going to talk about pancreatic cancer treatments first. One of the reasons pancreatic cancer treatments have been so hard to develop is that the mutation that's known to be present in 95% of pancreatic cancers, known as a KRAS mutation, just doesn't have effective treatment options. And for the longest time, we all thought that it's going to be undruggable. But things have changed now.
Only Oncologists in the Building is sponsored by DocUpdate, a physician-founded platform built to help you navigate the delays that stand between diagnosis and treatment. DocUpdate provides free, HIPAA-compliant tools that accelerate access to care. DocUpdate serves as a nexus for prescribing, medication samples, patient assistant resources, and AI medical translation, so care doesn't get delayed.
With so many new treatments making their way into the clinic, it can be hard to keep up with all the different information that we need to know to help support our patients when they need our help. DocUpdate makes that easier through its concierge tool. You can use the concierge tool in DocUpdate to request samples and patient resources on the medications without chasing down the manufacturers.
We're all in the business of trying to help our patients, and that includes thinking about clinical trials in oncology and in other specialties. It's not always easy to do. We look at clinicaltrials.gov website, and it's a little hard to navigate in terms of eligibility and if the patient sitting in front of me is eligible or not. So beyond that, DocUpdate is working on a new tool, a clinical trial navigator, to help connect patients to relevant clinical trials for them, pairing the community with academic oncology. It's part of a broader push to keep all the tools in one place.
So I'm really excited to talk about this data. But before we jump into the data, I actually want to talk about something that I think a lot of our listeners may have known about, which is the Ben Sass story. And I think what really came up with that was, and what was really striking was, and just kind of a primer on what happened, which was Ben Sass, who was a congressman, was on this drug that we're going to be talking about, and he developed a pretty extensive facial rash. And, you know, there was a big news article about it, and it kind of went viral. Everyone was talking about this big rash that came with this drug. And I think that detail stuck with a lot of people. One, because we know that any rash on the face can be very jarring for patients. And so in addition to us talking about the tumor response, I think in our excitement for promising practice-changing drugs, we have to think about the first thing that patients are going to experience, which is toxicity. And so that's why I think this is such a good conversation right now. But to briefly ground us all in the trial data that we have so far, RASolute 302 was a globalized randomized phase 3 study in previously treated metastatic pancreatic cancer. And it was pancreatic ductal adenocarcinoma, which is the more common kind of pancreatic cancer. And it compared a pill, once daily, daraxonrasib, versus whatever the investigator's choice was for systemic chemotherapy, which has classically been what we give to all of our patients. And according to the company's top-line release, all the study met its primary and secondary endpoints, but the big line is that the median overall survival for the patients taking the pill was 13.2 months, compared to the group that was getting that second-line chemotherapy was 6.7 months. So almost double overall survival, which is like so exciting and huge and crazy and really exciting in this patient population that we really needed better treatments. And to your point, what you said, Shalon, is so accurate, that we thought RAS was going to be undruggable forever because of how the protein works. And so,
and just to put this in perspective, one of the medications that's approved for pancreatic cancer, that's been approved for pancreatic cancer for decades, was approved on the basis of a study which showed an improvement in overall survival of 2 weeks. So for us to talk about a treatment that's now being developed that potentially can double survival for someone with metastatic pancreas cancer is just...
Exactly. I mean, it's like, I think there is a stat out there about the number of clinical trials in GI oncology, at least specifically, that have shown more than a 3-month overall survival in the past decade is like less than 5. And so really seeing a doubling in overall survival is kind of, unheard of, crazy, so exciting for our patients. But one mistake that I think people may make is assuming that rash is just a nuisance toxicity. And I think it's something that we, when we think about life, right, we think about, oh my gosh, this drug is going to help prolong life, double someone's overall survival. It is so important to think about what that quality of life looks like. And so I think thinking about the toxicities proactively is extremely important as we're entering this new phase of, KRAS inhibitors, where how do we make sure that we're preserving this quality of life that we are able to offer to patients? And so what do you guys kind of think about? I'm curious about what you guys think about the rash, how you guys think you're going to be managing it in practice. Any thoughts about that so far?
Scott Pelly, the Ben Sass did, I think was a great service, right? It's a great service to the community, and also shed a lot of light on this, right? So a really big, very much a long in the works, long time coming advance. And as you both astutely said, the number of months is really not to be overlooked. It's decades in the making because of basic science research. But then when we talk about the quality of life, I think it's important for people to understand it's not new that people can have rashes and that extent of rashes. So I know when people look, I think it was on his face, and that's something that's more apparent than parts of the body that are covered up by clothing and no one else is the wiser. But I think I do want to make sure that we reassure people that these are manageable. We do think about it proactively, right? And it's not unprecedented. I think of drugs that are IV infusion that we call EGFR inhibitors in oncology. Cetuximab and panitumumab are common, are also called Erbitux and Vectibix, respectively. And patients who are watching this may have experienced this, but these usually produce what we call acneiform rashes. Basically, when you're a teenager and you got acne, it's basically the same thing. It's actually even commonly associated with good response of the drug to the of the tumor to the drug, and so that very well may be the case here, that to be determined. But I think it's very manageable. It's something that's striking, and people who are not used to it might be jarring for them, but it is something that's manageable, and we have to learn how to do that with this new class of drugs.
Do you guys think about it? Oh no, I was going to say, do you guys think about it proactive? Are you like prophylaxing? Are you thinking about doing that with these patients? Are you going to be reactive?
Mm-hmm.
When we talk about side effects and we talk about side effects being manageable, I think we also have to think about it from our patients' perspectives on whether the side effects are tolerable and whether the side effects are acceptable. For some people, having even a mild rash can be extremely devastating. It can lead to social isolation. It can affect their livelihood. It can affect their ability to interact. And for a lot of side effects, what I've noticed is if they are visible, it it um, it tends to for a lot of patients lead to conversations with other folks about their treatment and about their cancer, which sometimes they're not really ready to do. For other side effects like numbness and tingling, which we see a lot in GI cancer patients, it's not visible. People don't know somebody has it. Oftentimes they're not even painful, and people have a very different threshold of tolerating this. And as these medications, these new class of medications, which are adjacent to the EGFR inhibitors that we've had for a few decades, as these new class of RAS inhibitors come out, I think we're all going to develop new skills when it comes to anticipating who are the people who are likely to develop these side effects. When do we reduce the dose of the drug? When do we stop the drug? When do we start an antibiotic preventatively? And what other supportive treatment options do we have for our patients so that we can allow them to stay on as intense of a dose as possible without interrupting their treatments and negatively impacting their quality of life? Because when we're talking about any treatment for someone who has an advanced stage cancer or stage 4 cancer, it has to help them live better and it has to help them live longer. And we want to think about both those options at the same time.
Yeah, I think you bring up a really great point about visible toxicity, right? And I think we've been thinking about that for years and years and years in many cancers where people have to get chemo that has them lose their hair or causes them to lose their hair. And I think something that I've learned in my practice is that people sometimes feel ashamed that they are so upset or can't tolerate certain side effects. Like, I can't tolerate losing my hair. I can't tolerate a facial rash because it's not vanity, it's identity, right? So it's part of who we are, how we perceive ourselves. And things like a significant rash or losing your hair affects that identity. And so I think it's extremely important for us to make sure that, and to be clear, I absolutely think it will be manageable, right? So I think that, I think having these discussions is so important because I think we are going to be able to get ahead of it for these patients. But I think it is also important for us to realize how severe it can be for patients. And, the Ben Sass story, again, to your point, Emil, you said like the facial rash, it's very different from a rash maybe on your upper arm where you could cover it. And so I think, I just think these considerations are really important when we're thinking about the excitement of this drug, which obviously we're really excited about.
We need help from our friendly dermatologists down the street, down the road, down the clinic, to help us with answering all those questions for sure. Now, shifting our focus to localized, surgically removable form of pancreas cancer, that's only 10 to 15% of all cases of pancreas cancer. What do we do after it to try and eliminate and further reduce the risk that it will ever come back? In other words, establish a recurrence. And so chemotherapy is given to try and do that, but the risk of it recurring is exceeding 90%. So we clearly have to do better. Some of the efforts in recent years have focused on this principle of vaccination. So we think of flu vaccination in recent years, COVID-19. You get a vaccination in general for infectious diseases like viruses to try and prevent getting a viral infection or trying to diminish or decrease the severity of the symptoms you might get from such a virus. And so trying to apply that same principle, including the same strategies like mRNA, are being used in cancer, in pancreas cancer specifically. And it's not being applied to stage 4 metastatic cases. It's being applied in cases where it's localized, contained, and surgery is performed, but in addition to chemotherapy, trying to improve upon those recurrence rates, and long-term survival. Some of the things that we've heard about, including at the April 2026 annual meeting of the American Association for Cancer Research, we heard an update of an exciting trial out of Memorial Sloan Kettering that we had heard previously that included mainly patients with pancreas cancer and also colorectal cancer as an example. That was a unique example in which there was a tailored form of vaccination based on mRNA. And we all know that it's been in the news recently, but the science of it was proven, especially during the COVID era, with development of at least one or more formulations of the COVID vaccination. The idea was to take a patient's own tumor after surgery and to realize the signals called antigens or neoantigens that can be used as therapeutic targets for vaccine to suppress and prevent, or at least improve the odds that the cancer would not reform its cells into tumors that would then metastasize and make stage 4. So what was unique about this is they individually tailored vaccinations that were used in the post-surgical setting, and then included also treatment with standard of care chemotherapy, in that case the FOLFIRINOX regimen, a 3-drug regimen, and uniquely immunotherapy, atezolizumab. That's not usually used in this cancer, but it was a combined therapy to really rev up the immune system. And there was a response of the immune system. About 50% of participants, 8 out of 16 with the pancreas cancer. So it showed that there was a possibility of mounting a really substantial T cell response. And then the April 2026 update was really focusing on the people who had responded well over the subsequent years, and a 6-year follow-up showed that 7 out of the 8 responders were still alive. And then so, as we said earlier, with the survival data for a cancer that still, you would say, the 5-year survival rate is, if it exceeds 10%, it's just by a very small amount. That is remarkable for those patients. Out of the ones that had not responded, only a few actually had a significant immune response and were still alive, but there was a really great signal that far exceeds what we see. What do you guys think about that and that strategy and what we've heard in recent years? And it's not the only approach, but it's just the one that's made the news most prominently this spring.
Well, when we talk about vaccines, there are many different approaches for vaccines. We've talked about neoantigen vaccines, where we take specific proteins and synthesize those proteins and administer them back into the patient to elicit immune response. Here we're talking about an mRNA vaccine, which is generated specific to the patient's tumor and then is administered to elicit an immune response. I think this is a fantastic study. The fact that 7 out of the 8 people who had a response are still disease-free after such a long period of time is absolutely phenomenal. This is a really small study, though. It's from one center, granted one of the best cancer centers in the world. How is this data really going to shake up when it comes to the broader population? We really need to wait, and we are looking at and seeing that the investigators have already developed the next clinical trial to understand how this is going to function in a broader patient population. There are significant challenges here. Remember, we talked about only 10% of people diagnosed with pancreatic cancer are going to be eligible to receive surgery. Most of those patients are going to recur soon after surgery despite getting chemotherapy. And out of those people, only half of them received an immune response. So the number of folks who can benefit from this vaccine is certainly more than it would be without it, but it's a very select group of people who can benefit from this vaccine, and really trying to expand that number to understand why some people are not responding and how we can make them into responders, which goes into the points that you're talking. Do we combine them with other immune stimulating medications? Do we combine them with other vaccines? Do we combine them with RAS inhibitors or other targeted treatments that are coming down the pike? Are the kind of questions that we're really excited to see. But again, keeping this vaccine study for people with resected pancreas cancer in the scope of other clinical trials that have been done in this population, this type of disease-free response is extraordinary.
Yeah, I mean, I guess I agree that this is like incredible, obviously incredible news for those patients who did not have recurrence, and honestly, the science behind it is very interesting to see. You know, you take the tumor, you see what things make the tumor and that are different from your own body, and then you develop something that teaches your body how to attack it. And I think when we think about what's the most natural way to kill cancer, that feels like that might be something that a lot of people can get behind, that we're using your own immune system, we're just teaching it. I think my biggest question and the science that I would like to know more about, and I imagine that they will release, I hope they release data on kind of almost like the negative results of the trial, right? So you have your 8 that responded. I want to know everything about the 8 that did not respond, right? Why is it, I got to say that we tend to, and maybe I just don't know, flu vaccine data as well, but we tend to believe that, you get the flu vaccine, you're going to be generally, your body's going to make this immune response. Was it that, if they got this after they finished chemo, that their body wasn't capable of mounting this immune response? Was it, or was it, and so if there was a long enough lull after chemo and then you gave them the vaccine, possibly, is that like, was there a temporal association? I guess, we don't often see negative studies, right? We see the good things get published, but I would love to know more about why those patients didn't respond, because I I think that's going to be really important to move this kind of forward. So that's kind of my general thoughts on that.
Yeah, and the logistics, right? The logistics of finding someone's resected tumor, getting that tissue, sending it to the lab that will then generate the vaccine, bring the vaccine back for administration. We've seen for CAR T cell therapy, and we've seen for other bespoke treatments that's not insignificant, and those barriers can significantly limit the number of centers, the number of institutions, the number of zip codes of people who can participate in these types of treatments. So long way to go, but very exciting path.
Yeah, these trials are very detail oriented. They're very hard to do. I like the word you used, bespoke, like suits. To do that tailored to each individual patient's tumor is extremely hard to do, having gone through it myself. But I would say also the phase 2 trial is expanded. I think they're going to enroll at least 200 plus patients. And so since I fielded a lot of calls in my own clinic about it and requests for referral, just emphasizing again, it's for patients who've had surgery and no evidence of cancer after the surgery visible on a CT scan, but it's not intended nor designed for patients who have stage 4 metastatic form of pancreas cancer, unfortunately, or other forms that are not surgically removable at this time.
But I think all of us will agree that the one intervention that can dramatically change the outcome of pancreatic cancer and the face of pancreatic cancer as we know it is if we can just help identifying pancreatic tumors when they're still resectable, when they're still operable, and when they haven't spread to other parts of the body. And one of the challenges for pancreatic cancer has been the fact that there is no known effective screening or early detection measure because of where the tumor is located. It's in the back of the belly. There are bowels looping around it. It's the density of the pancreas compared to the organs around there makes it hard to identify, and hard to identify tumors within the pancreas. And the pancreatic tumors themselves are known to cause inflammation, which causes the borders around the tumor to start looking fuzzy in a lot of the scans. So even when you bring a bunch of experts together, some of them will have a preferred modality of a CT scan to look for pancreas cancer. Some will say MRI, and some will actually want to do an endoscopic ultrasound where you pass a camera from the esophagus into the stomach and do an ultrasound from the inside. And there isn't a one single screening test like we have for breast cancer, colon cancer, or cervical cancer. So a really exciting study has come up to really evaluate the impact that artificial intelligence can have for detecting pancreas cancer early. And what's really exciting about this study, which came out from the Mayo Clinic and was published in the journal Gut, is they looked at non-contrast abdominal CTs. These are your run-of-the-mill CT scans that you'll get if you go to an urgent care or an emergency department for, let's say, a gallstone, or for a kidney stone, or for appendicitis. And they were able to go back and find patients who had pancreas cancer and had scans for the preceding couple of years that were read as being completely clear. And they trained artificial intelligence models to see if there was anything in those early negative scans that could predict that someone's going to develop a cancer later. And they compared it with other controls and did a very sophisticated analysis to train the model and then validate their effectiveness. So then what they found is that the AI model is able to identify some changes in the shadows in otherwise previously clear CT scans 67% of the time. And when they went back to the radiologists and asked them to look at those scans, knowing that there is a tumor and they're looking at it with a bias lens, they were only able to find it in about a third of those tumors. So this non-AI tool on non-contrast CTs is allowing us to layer an additional AI tool on clinically collected CT scans, which can identify pancreatic cancers on an average 1 year before they become visible on CT scans, and as long as 3 years before they actually become visible. And there are a bunch of different tools out there that are being developed, but very exciting work, which is completely changing our ability to extract information from CT scans that are just not visible by the human eye. These are by definition negative scans most of the times, yet the AI tools are able to differentiate at a pixel level, at a radiomic level, using radiomic tools, differences to demarcate pancreatic lesions that otherwise would have been considered invisible.
Yeah, I think that it really begs the question then. So if this works and is validated, then who are the people who should be getting those scans to be run through this algorithm? Is it people with a family history of pancreas cancer? Is it people who are all smokers? Right? I mean, there was a time not so long ago, and you guys remember when we knew for how many decades, if not 50 to 60 years, that smoking causes lung cancer, but not everyone was getting the low dose CT screening that's been more prevalent in the last decade. That's relatively recent development. Is that the next thing on the horizon, using this technology for detecting pancreas cancer early?
Yeah, so I think this is really exciting, obviously, and I think that there are a lot of ways that AI is being misused in our society. This is not one of them, right? Like this is exactly why AI is going to make things better, right? And why we have to, as medical professionals and in the medical field, embrace it because we will be able to help people, and this is a great example of that. Some place where I'm a little bit worried, I want to temper my excitement, is actually not necessarily with the technology. I think it makes sense that patterns can be picked up. If you have thousands and thousands and thousands of scans that you're of data that you're putting into this AI mind, is who gets the scan in the first place uh, outside of what is recommended, right? So I think this feels almost, I feel like sometimes I'm a downer on this, where I always say, like, last episode I said feels reminiscent of the microbiome, and now I'm going to say this again. It feels a little bit reminiscent of our full body MRI, right? Where who gets the full body MRI? It's people who can afford it, right? It's people who and how do we make sure that this technology is actually rolled out without giving people too much exposure to CT scans? Like, how often do you get it? We know pancreas cancer evolves very quickly, right? I don't know that a yearly scan would be enough, right? If we know what we know about how quickly pancreas cancer grows. And so I think that I definitely have some questions and hesitation about how it's going to be rolled out. I think the technology is very exciting, but I worry about who specifically is going to have access to these technologies, and are we going to be over testing people in efforts to find this subset of people that get pancreas cancer? And so that's some of my questions.
Yeah.
Implementing artificial intelligence in the real world is a whole can of worms by itself. Now, if you have a self-driving car that's been trained on the clean, sunny streets of San Diego, is it going to function as well in a rainy, cloudy New York street? Or does it have to be trained all over again? Or are there certain components that you need to develop and train all over again? So one of the challenges for these models is how well will the trained model that's been trained on clean data, usually from a couple of different centers, on a couple of different machines with a couple of different protocols, how well will it apply in the real world? What makes this specific tool exciting for me is when I think about CT scans, the variables are the machine that's being done, the slices that are being generated, the different reformatted scans, and oftentimes variations around the contrast, which is the IV dye which is injected, the timing of the dye, the nature of the dye, the other values around the dye. But Shruti, to the point that you're making, this is an AI tool that's been generated on non-contrast CTs done for completely other reasons. So
Mm.
we should be thinking about who are the people who will get these on a routine basis once these tools are validated across different settings. Maybe it's older people with new onset diabetes. Maybe it's people who have a family history of breast cancer or pancreatic cancer in their family. Maybe it's everybody. I don't know. But right now, we're just able to go apply these such artificial tools, artificial intelligence tools, on CT scans that people have already gotten in the last couple of years, maybe through a quick trip to the urgent care or the doctor's office.
And let's not also forget, and it's something we discussed on a recent episode, multi-cancer early detection using ctDNA, circulating tumor DNA, cell-free DNA, unless you have cancer, then it's called ctDNA. But blood-based testing that could be paired with this, are they rivals? To be determined. But I think of that 3 years, when patients ask, how long did I have this once a pancreas cancer is actually diagnosed? I don't say 3 years, I speculate, but again, it's never really known unless you say, if someone were in an emergency room for some reason and for some other completely opposite reason had a CT scan, and in retrospect, you look at it, you can find it, this AI may be able to answer that question. But I usually don't say 3 years. I might say, who knows, maybe 6 months, maybe 12 months, but I can't imagine it'd be longer than, 12 to 18 months. But maybe this proves us wrong. We're going to find it. And then maybe this is where AI is taking over in a great way. As you said, Shruti, that this is where we, with its keen eye that we humans don't have, it's going to pick up things.
I
And
think that's a
do more
really
scans.
interesting point that you made, that I say the same thing. If it's obviously, if it's a pancreatic neuroendocrine tumor, I say longer, right? But if it's a pancreatic adenocarcinoma, I say, I don't know, but I can't imagine, right, more than this much time. And so I wonder if this also teaches us a little bit about biology. Like maybe there isn't, maybe what they're picking up is dysplasia, right? It's not necessarily cancer cells, but it's just abnormal cells that are at risk of turning into cancer. And so that's a really interesting point, that if we could catch it soon.
Well, what if somebody has an artificial intelligence tool that says on a non-contrast CT that this person has developed something, but you're not seeing anything on the scan, you're not seeing anything on a CT, you're not seeing anything on MRI. What are you going to do? Are we going to wait and see whether something's going to develop? Are you going to do surgery up front with the suspicion that there could be a tumor in there? We don't have good answers for that. So there's a lot more work that needs to be done in this space. That's a great angle.
I mean, I just think that this is incredible work that we've been talking about, right? Early detection. Then we're saying, okay, if you detect it early enough and you have the surgery, how do we make sure it doesn't come back? And then, unfortunately, we know for most of our patients who do have stage 4 pancreatic cancer, having this new treatment option is life-changing. And I think that people who have been treating pancreas cancer for decades, this is so incredibly exciting and important, and for patients especially. And so I think we've just talked about some pretty crazy updates in pancreatic cancer that are going to change the landscape. We don't know exactly how, but all 3 of these, I think, are going to change the landscape of pancreatic cancer in the next decade. And I'm really excited to see how we can go from this cancer being the 3rd most common cancer that, cancer-related deaths. I want that to not be number 3, and I think that all 3 of these advances are going to help us get there. So thank you guys for listening. We obviously love talking about pancreatic cancer and these advances, and we're going to be here next week to tell you more.